Hello, everybody. It is a pleasure and honor to participate to this virtual session of the Society of Neurocritical Care India and to contribute with a lecture on the excellence in neurocritical care. I have initially thought to deliver the lecture live, although through the web, but to avoid unforeseen complications, I rather decided to record it, so I will not miss the meeting. Along my presentation, I will also display some paintings from Tintoretto, a painter from Venice in the Renaissance. And in particular, he depicts several scenes of saints that are taking care of sick patients. In this image, as you can see, he's taking care of people with plague. And this is something that we are confronting in every days of our life. So I thought it's appropriate to share this vision, this perspective from the Renaissance. Excellence in neurocritical care, and actually which is the role of neurocritical care in treating patients with acute brain injury, is debated since more than 2 decades. And this is a report from about 130 patients that were treated either in a general ICU or in a specialty neurocritical care unit after intracranial hemorrhage. As you can see from the reported data, the mortality rate was lower for those patients admitted to a specialized neurocritical care unit, as the length of stay and the cost of care. So according to this preliminary report, the role of neurocritical care unit, when staffed by specialists, trained intensivists, and dedicated nurse, associate with an improvement in quality and efficiency of care. More recently, actually this year, Neurocritical Care Society accomplished a worldwide surveillance, the PRINCE study, that collected the evidence from more than 30 countries and more than 50,000 patients. And they reported several figures that associated with the daily activity of neurocritical care units. Of interest, that I have selected few. The most common diagnosis for neurocritical care admission are subarachnoid hemorrhage and intracranial hemorrhage, but also traumatic brain injury patients. These data report that patients with those kind of conditions, when treated in a neurocritical care unit, have a lower likely mortality rate. So the odds ratio is reduced to 0.72. It's also interesting to underline how in the various settings these data have been recorded, there are major differences in end-of-life care practice. That is among the most relevant aspects of our daily practice. I would like to underline another information from this report, and so that according to the recorded evidence, rather than the educational and professional background of the healthcare, of the individual healthcare providers, is relevant for an effective neurocritical care assistance to develop dedicated protocols and to compliant with those protocols. So we have to think what we want to deliver when we face a patient that might be appropriately treated in a neurocritical care unit. For this reason, we will go through several and different conditions, and in detail, I will address briefly some of the aspects of traumatic brain injury management, the management of subarachnoid hemorrhage, of the patients with acute ischemic stroke, and those that are admitted to a neurocritical care unit after brain surgery. And last, just a couple of slides before the conclusions, I would like to point out a few concepts that address the specific need for communication and research in our environment. So, which is the role of neurocritical care in traumatic brain injured patients? This is a study, a report from more than 3,000 patients admitted to neurocritical care after traumatic brain injury. The cause of the traumatic brain injury can be related to fall in about 50% of the cases, or motor vehicle accident in 33% of the cases, and assault in 12% of the cases. As you can see, the figures that relate to the mortality in this subset of patients changes a lot. While after a fall, the mortality rate at 6 months has been 32%, in those having a motor vehicle accident, the mortality rate was down to 22%, and after an assault down to 17%. So different conditions associated with the different risk. And the possible explanation for the increased mortality in patients after fall is that this community might be represented mostly by elderly patients that fall in the house. It's important to consider that beside the overall mortality is relevant for our subsetting to describe the quality of care we deliver, what we consider at once the unfavorable outcome. So not only death, but also severe disability. And it's important also to remember that patients treated in a specialized neurocritical care unit have lower risk of early mortality, about half when compared with general ICU, and higher cost effectiveness in the delivering of care. But this evidence can be challenged when we consider different subset of patients, always in the boundaries of traumatic brain injury. This study addressed the course of patients that develop intracranial hemorrhage after traumatic brain injury, and about those patients treated in the ICU or admitted to a ward, to a general ward. These patients were mildly severe, not severe patients. And the data at 6 months follow-up shows how the functional status was similar after either ICU or general ward treatment. So in this subset of patients, it's clear how the benefits provided by neurocritical care treatment is limited. The benefits and the risks associated with the advanced treatment relates with the grade of evidence-based medicine criteria. And we know that unfortunately for the treatment of traumatic brain injury, there is only one level 1 indications. And even for the other level of indication, the level 2 and 3, the proven beneficial treatment are very limited. We all know that we should avoid hypotension, hypoxia, and very important to avoid hyperventilation, and to use hyperosmolar therapy when needed, but few remember that the only level 1 evidence-based criteria for traumatic brain injury patients is to avoid steroids. So as you can understand, the support we have from the literature is extremely limited. I've also brought to your attention how nutrition is among the few concepts that are supported by relevant evidence, despite sometimes overlooked. This study addressed how the third-tier therapies as deep sedation and hyperventilation or the use of decompressive craniectomy should be reserved to those patients that have a refractory intracranial hypertension. But even in those patients, the use of intracranial ICP monitoring devices has not been proven beneficial. So we should limit this approach to selected patients. And back to the nutrition, I would like to underline how delaying the onset, the beginning of nutrition in patients with traumatic brain injury associate with 2 to 4-fold increase in the risk of death. What can be said about the management of subarachnoid hemorrhage? This is an extremely interesting and challenging environment. It's true that according to this report that compared the outcome and the risk presentation of 2 different periods, 2004 to 2007, this was in a university in the US center, when the neurosurgeon was on call. Patients admitted in that period were compared to patients admitted in the subsequent period, 2009 to 2011, when the neurovascular team was in hospital. And the data, the recorded data, shows how the patients treated in the latter period had a much better functional status at 3 months follow-up. And also the good recovery was higher. So in this experience, to have a dedicated team for neurovascular patients associated with an improvement in the functional outcome. Is also true, as it appears from this survey studies that we promoted in various European countries, that there is a huge variability in the actual delivered care. And this is also proven when we consider the difference in protocols. As you can see, for instance, only 18% of neurocritical care centers have a treatment protocols in some countries, while in others goes up to 50%. So this huge variability explains and associated with the differences in the delivered care. This is a systematic review of the literature that relates to guidelines on subarachnoid hemorrhage management. And as you can see, over time, we had between 1994 and 2016, in a little bit more than 20 years, we had more than 10 different guidelines and 10 different surveys. So not only there are few proven principles for the treatment, proven and shared principles for the treatment of these patients, but the amount of guidelines and surveys, 1 every 2 years, shows and prove how things evolves. And a clear demonstration of the evolvement of the changes over time of the management of these patients is reported by the course of the so-called Triple H therapy This was proposed in 1994 on the basis of an expert consensus and was designed to prevent vasospasm after aneurysm surgery. But 10 years after, this approach, this therapeutic approach, shifted from preventive approach to reasonable approach. And finally, in 2011, 15 years after, the Triple H therapy was definitely abandoned because of the increased harm, especially due to the excess of fluid administration. But there are other aspects that we should manage in treatment of patients with subarachnoid hemorrhage. One that I consider especially important is to avoid excess of oxygen. You see, in this study, it's clearly reported how hyperoxia that can only be iatrogenic associated with 2.3 increase in poor outcome and 3.1 increase in delayed cerebral ischemia. So hyperoxia should be aggressively avoided in patients with subarachnoid hemorrhage. And similarly, occurrence of hypocapnia, so the excess of ventilation, associate with the most unfavorable outcome and higher incidence of vasospasm. We mentioned already how an excess of fluid infusion predicts a poor outcome. And so this should be tightly monitored. But I would like also to point out how the analysis, the sequential analysis of the cerebral spinal fluid can provide us useful information to define the possible outcome. Acute ischemic stroke. This is another group of patients that can eventually benefit from the treatment in a dedicated and subspecialty environment. And it is proven that some variables, including mortality and functional recovery, are better managed in dedicated centers. And this is particularly big because of the better management of arterial blood pressure and of seizures. Of note, it is important, it is necessary to select the patients that might be more likely to benefit from neurocritical care admission. And those are only patients having the highest severity of stroke. As you can see, the issue has been further studied. This is a large retrospective cohort, almost 5,000 patients, and reported that in patients with acute ischemic stroke or hemorrhagic stroke, reason for admission to ICU are for the largest part due to the reduced consciousness or cardiac or respiratory complication or the need for mechanical ventilation. It's interesting to note how poor neurological status, need for mechanical ventilation or advanced age and intracranial hemorrhage associate with a higher risk of poor neurological status and increased mortality. So in these patients, patients at a high risk, the assistance, the treatment in a neurocritical care unit might be life-saving. Also in these patients, it is important to avoid hyperoxia. Here you see a paradox that eventually patients presented with hypoxia had less risk to die than those treated with severe hypoxia. And it's important to remember that these patients might benefit, might need dedicated treatment protocols. And I would like to remind you how in patients with acute ischemic stroke, the use of erythropoietin seems to improve long-term neurological outcome after acute ischemic stroke. What about the treatment of neurocritical care treatment of patients undergone brain tumor evacuation? In these patients, we should remember that the earlier extubation associated with less systemic stress and reduced systemic oxygen extraction. So if possible, if these patients can be extubated, they breathe normally, they have gag reflex, they have normal body temperature, it is better to run for early extubation in the operating room. But we should also remember that in neurocritical care, in neuro patients, the most stronger predictors of effectiveness in extubation, of successful extubation, is the neurological status in the postoperative period. So these patients are not like patients with having chronic respiratory syndromes that can be managed considering the efficiency and the role of mechanical ventilation, but rather we should assess the neurological status in order to select patients that are suitable for extubation. There are other aspects that are important, and I would like to point out how to manage cerebral edema. In our experience, the associated use of mannitol, furosemide, and potassium-sparing diuretics associated with the less waste of potassium, and so more stable plasmatic concentration of this electrolyte. And of great importance is also the prevention of deep vein thrombosis and pulmonary embolism. This is an experience in more than 4,000 patients undergone craniotomy for brain tumors. And I would like to underline how 3% of the patients developed deep vein thrombosis or pulmonary embolic event, and in 86% of these patients, there was actually ongoing a treatment, a prophylactic treatment, the low molecular weight heparin. So low molecular weight heparin might not be enough in patients with neurological deficit, and we should consider to associate it with physical measures, And it's also important to remember which are the patients that are at higher risk for these complications. And I would like to recall how the poor Karnofsky performance scale, the high-grade glioma, and older age are the strongest predictor of an increased risk for deep vein thrombosis and pulmonary embolism. Is it proven to be useful to admit and to treat in a dedicated neurocritical care setting patients undergone brain tumor resection? No, actually it's not that way. So this specific course of treatment should be selected for a limited number of patients. And here is a paper, is a review article where we have summarized the criteria that associate with a higher likely of beneficial admission to a neurocritical care unit. Here on the left high are criteria that indicates the need for ICU treatment, neurocritical care treatment after elective craniotomy. As you can see, advanced as a physical status, diabetes, epilepsy, longer surgical procedure, of course, the need for vasopressor, and delayed emergency. I would also include in this list a failure of cranial nerves, especially the gagging reflex. There are other criteria for traumatic brain injury patients and patients that suffered from acute ischemic stroke or intracranial hemorrhage. These are evolving concepts that needs to be defined also according to local protocols. Here we are to the last session of the lecture, and I would like to point out two concepts. One is the unique need of healthcare provider to relatives communication in the setting of neurocritical care. We all know that eventually the relatives will never contact again their beloved, and the only thing that we can do is try to assist the relatives in the best way possible in this passage that is accepting the extensive and eventually deadly brain damage. So it is important to establish an approach, and I would say that being the most human and compassionate is extremely important. And I would also say respectful. This is a study a few years ago that brought together the feeling of the next of kin, the surrogates, and the physicians in within the context of neurocritical care treatment. And is especially astonishing to note how the requirements from the relatives and the approach generally used by most of the doctors do not match. Relatives were asking for numerical figures and indexes of probability, while a majority of doctors, 75%, reported to intentionally omit numeric figures. This is a mismatch that should be filled somehow. We should try to deliver information as we are requested to. And last but one are the criteria to drive research in future. This is a recent paper published in JAMA Neurology that highlight 5 possible fields of interest in research in neurocritical care. Of course, number one is to expand the biology research. We are not profiling at all the genomic factors and matching the individual characteristic with the physiological response to the ongoing acute brain injury. We should know more about this. We should consider that in a setting like neurocritical care, even small success are extremely important. So, of course, optimizing hemodynamic management, ventilation, very important, electrolytes, preventing infections, glycemic management. These are all minor aspects that altogether might turn into be a higher quality of care. And design and share with your group targeted interventional strategies. We should try to focus on what is important for our patients and try to design a dedicated protocols that fulfill the various aspects of the need of our patients. Once we develop a protocol, it is important that this is a user-friendly protocol. I've seen over my life a lot of algorithms, so difficult that I thought of myself, I'm not bright enough. Clear mind generate clear paths. So when you have a clear idea of your strategy, there should be a way of generating a clear message for your colleague. And the last point is to work together. Work together within the team, within the surgeons, within the radiologists, and within the consultant, infectivologists, nutritionists, and so on. So we should work together and put at the center, not ourselves, but our patient. So getting to the conclusions, as you can see, we went through several points. I hope this was of some interest. To highlight the most relevant points, I would say that currently the available evidence provide conflicting results on the impact of neurocritical care subspecialty management on the outcome of patients with acute brain injury, both in terms of mortality rates and of long-term functional outcome. And it's important to remember that there are specific hints that characterize the needs of brain injury patients. I have cited some of them, of course, hemodynamic management, ventilation, appropriate nursing. This is very important. They are a big part of the team. So prevention of infection and pressure lesion are often in the hands of an appropriate nursing treatment. Nutrition is extremely important. And again, communication, both within the team and with the relatives, is very, very important, along with research in the future. I want to underline another concept. It's not the designation, the label outside of your door that makes you good. So this doesn't change much. What it changes is how you deliver care in your centers. So I hope that this lecture will contribute to improve the level of quality of care. Please consider to contact me for any doubt, any question, or any cooperative project. Thank you for your attention.